Hi there, my name is Shmuel, also known as Medicura, and welcome to my series on UKMLA revision study session thing. I haven't come up with a name yet, as you can tell, but today we will be looking at appendicitis, and this video is intended for those who are sitting the UKMLA exam. So, what is appendicitis? So we have our cecum here, which is the initial part of our intestine, and towards the start of it, or the end of it you could say, is the appendix. And when this appendix gets inflamed or irritated or infected, then we get appendicitis. That's all it is. Okay, wonderful. And obviously we get symptoms as a result of the inflammation, and it can spread and it can be quite detrimental to the individual if not resolved. So imagine me and you, we both go to A&E, and what happens is we see Adam, a 21-year-old who's come in with stomach pains, and he says to us this, that he's had this pain since last night. It was near his belly button. It's moved down to the right lower side. He does feel a bit sick. He hasn't eaten anything today. He does feel a little bit bloated, and he's vomited once. This is a crystal clear presentation of appendicitis. But don't worry, we're going to talk about the symptoms later on. So, what are the symptoms? First one is abdominal pain. You get pain with this. Second one is also abdominal pain, but a special type, which is periumbilical pain. The idea that you get pain around your belly button. It starts off there, but then it ends in the right iliac fossa. And when it shifts, when the pain shifts, matters have gotten worse. Does that make sense? And there's a reason for that. When initially the appendix gets inflamed, so let me draw the appendix here. There's a thin sheet covering it. That thin sheet is known as the visceral peritoneum. It covers the outside layer of the appendix. When that gets irritated as well, it will send a signal to the brain. The brain can't exactly detect where this is, and it will be like, okay, it seems like it's somewhere near the periumbilical region. And there's the concept behind this is referred pain if you want to look it up. Now, initially, that's what happens. That pain starts off in the periumbilical region. When the pain spreads, or when the inflammation spreads and the infection spreads, it will spread to the parietal peritoneum, which covers the inner lining of your abdominal wall. When it spreads to that, the brain can then exactly tell you where the pain is originating from, and that's when the shift happens. The shift happens from the belly button region all the way down to the right iliac fossa. When it shifts, matters have gotten worse. Does that make sense? Okay, good. And if not, comment down below. Now, children, they will report pain on coughing, worse on coughing, and also going over speed bumps. Individuals may vomit once or twice, but vomiting is not as common. Diarrhea is also relatively common, but especially in those who have an appendix located towards their pelvis. Let me explain. So a lot of people have the appendix, around 63 to 65% of people have the appendix, which is retrocecal. The idea that the appendix is behind the cecum, okay? So it's not anywhere near the appendix or the pelvis. But those individuals who have an appendix located near the pelvis, this appendix is close to the rectum. And when this is close to the rectum, the appendix that's inflamed and irritated will irritate the rectum, and as a result cause diarrhea. That is essentially it. Okay? So a lot of the anatomy will dictate the symptoms an individual will get. Anorexia is one, poor appetite, nausea. Now, if you struggle to remember this, there is a mnemonic that you can learn, which is called appendix. A for abdominal pain, P for pain on movement, P for poor appetite, E for emesis, so vomiting, and N for nausea, D for diarrhea, I for iliac fossa tenderness, and X for extra clues like guarding, rebound tenderness, and fever, which we'll look at next. So let's have a look at investigations and examinations. So there are 3 things that you need to remember. The first one is rebound tenderness or percussion tenderness. The idea is that when you press down on someone's belly like this, it will cause pain when you let go. And likewise as well, when you percuss their belly like this, it will cause pain. Okay? Guarding. What is guarding? Guarding is the involuntary tension of the abdominal wall. Sorry, messed up my words there. And that essentially happens almost like as a protective mechanism. So when you touch, it will automatically tense up. And that's when the individual has guarding. Thirdly, rigidity. Rigidity is basically when the stomach or the abdomen is completely stiff. And that's not always seen, but especially the first two, that is quite common. Now, there are some classical signs you do need to know. First one being Rosving sign. So Rosving sign is basically where you palpate in the left iliac fossa. So I'm going to palpate here. So in the left iliac fossa. And what will happen is when we let go, it will cause pain in the right iliac fossa. And that's essentially it. That's all Rosving sign is. Okay, so that's something that you can try in your OSCE. Second thing is psoas sign. The idea is pain on extending the hip, and especially it's common for those individuals who have a retrocecal appendix. McBurney sign. So there is a thing called McBurney's point. So if I draw it right here, and don't worry, on the next slide I will show you. So we have our belly button here, and we're looking at the right iliac fossa, which is around here, and then also 2/3 of the way down from the belly button. So in line with the ASIS, or the anterior superior iliac spine, or the right iliac fossa, is basically where you'll find McBurney's point, which is this. When you palpate on this region here, it will elicit pain, and that's McBurney's point. And then you can do a digital rectal examination as well, and that can cause pain. So especially for those individuals who have an appendix located towards the pelvis. Now, you can see here we have point number 1. So on the image on the right, that is McBurney's point. So I talked about point number 3, which is your ASIS, or your right iliac fossa, and then point number 2, which is your belly button. Now, 2/3 of the way down diagonally, in line with the ASIS, going towards the ASIS, 2/3 of the way down, we have McBurney's point, which is point number 1. Now, the image on the left here, we have different locations or different anatomical variations of the appendix in terms of position. So we have one that is retrocecal, we have one that is pelvis, located towards the pelvis, postileal, preilial, subileal. But the main one that is very common is 63% of the population have retrocecal. There is a bit of pathophysiology behind why the pain shifts from the belly button all the way down to the right iliac fossa. So let's have a look. So the idea is that there is an obstruction in the appendix, or sometimes an infection, or that obstruction, what happens is it makes appendix swell. When it swells, it gets inflamed, it gets irritated. And because the visceral peritoneum, which is on the outside, sorry, let me not draw on my face. So the visceral peritoneum, which is on the outside of the appendix, that will also get irritated. And when that gets irritated, it shares nerve supply with the T10 dermatome, which is around your belly button region. And that is initially why you feel pain around your belly button. It's simply the idea that the brain can't tell exactly where the pain is coming from, so it will locate to the nearest location, which is T10, which is around your belly button region. And when it shifts, so when the shifting happens, like I said before, that is when it reaches the parietal peritoneum. So the inflammation is spread, and that's bad. And it's in the parietal peritoneum, you have precise sensory nerves that can locate exactly where the pain is originating from. And that is when the pain becomes more sharp, more intensified, and it's well defined as well. But initially, it's central, it's dull, it's vague. Does that make sense? Perfect. Now let's have a look at investigations. Now, investigations, we're going to be doing our typical bloods, ECG, VBG, you name it. Now, in bloods, you will typically find high white blood cell due to infection and high CRP due to inflammation. Urine test. You want to do a urine test to eliminate anything such as pregnancy, renal colic, or UTI. And then in terms of imaging as well, this is really important. When it comes to imaging, you want to use ultrasound first for females who possibly have pelvic pathologies, and then children as well. And then for everyone else, you want to do contrast enhanced CT imaging. And the reason why for females and children you use ultrasound is because it's less radiation in comparison to a contrast enhanced CT image. And then for pregnant women, you would do an MRI scan. And then enhanced contrast CT is highly sensitive, around 98.5%. So just be aware of the imaging that you would use for different individuals. Now, there are a couple of differentials. Now, differentials being this list right here. So we've got gastroenteritis, Crohn's disease, peptic ulcer, UTI, ectopic pregnancy, you name it. So that's just something to be aware of. Especially when you're taking history, you can almost like tick things off, cross things off as you go along. What is the most common reason for a blockage to occur in the appendix? One of the main reasons is the hard lump of stool, or the fecalif. I think that's how you pronounce it. You know, half of the words in medicine I cannot pronounce. But basically a hard lump of stool in your appendix. When that gets lodged in there, that can cause infection. Sometimes you can get normal stool in there, and also swelling of the lymph tissue. That can be quite common as well. And other rare causes, such as parasites, such as schistomiasis, which is basically a parasite found within freshwater snails, and those freshwater snails are found in rivers and ponds. And so when people go, I don't know, skinny dipping, they can get those parasites. And then obviously nerve immune reactions, which is still being researched as well. Now, what happens after the blockage? Well, basically there's trapped mucus that builds up, causes the appendix to swell. So it's all down to swelling of the appendix and inflammation. And when the pressure increases, bacteria multiply. And when they rapidly multiply, then it will lead to symptoms such as loss of appetite, nausea and vomiting, dull belly button pain, so that visceral pain that we talked about initially. And sooner or later, it might burst. In terms of management, what do we do? Well, very simply, you have here the gold standard, so appendectomy. So the idea that you will do keyhole surgery to actually remove the appendix. And you want to do this laparoscopically first, and then if need be, you can resort to an open approach. You don't really want to start off with an open approach, especially if you can make a smaller incision on someone and still give the same effect. The second management is Cooper's abdominal lavage. This is especially common in those who have a perforated appendix, where the infections just spread everywhere, and you all have that gunk in the abdomen, and you want to get rid of that. So basically, you get sterile fluid and just wash out the abdomen. And IV antibiotics are given prophylactically, so before surgery. And the reason being is that mid-surgery, it might perforate, it might, spread everywhere. And so we want to make sure that they are well prepared before infection, if infection was to occur. Now, having IV antibiotics alone for appendicitis is not as effective, as up to 20% of patients still have to come back within 12 months to get their appendix removed. So that's something else to keep in mind. What are some of the complications? Perforation. When perforation happens, you get generalized peritonitis. Peritonitis is basically inflammation or tenderness of your peritoneum that we talked about. So your parietal peritoneum or your visceral peritoneum. Sometimes you can get a mass or an abscess, and the really critical endings can be sepsis, and you don't want to get to that point. Is there a scoring system for appendicitis? Yes, there is. You can use the Alvarado score, which you can use the mnemonic of Mantrell's, and it's on the screen right here. And that's essentially it. So this is appendicitis. So what I'd recommend for you to do now is to go into PassMed, attempt some questions on appendicitis, see how it goes, and then come back if you've got any questions or anything that you feel like I missed out. And hope you enjoyed the video. And if there's anything else that you would like me to cover, then let me know. And if you found it helpful, then let me know. And yeah, that's essentially it.